My name is Tani Njoroge. I work with HealthStrat as a supply chain advisor. I'll be presenting this. I'm doing this presentation on behalf of Dr. Andrew Nyandigisi, and it is on the digitization of the FCDR. This is a tool that is found in all health facilities and is used to report program commodities. And recently, we also have an FCDR for essential medicine that has been recently been developed and already in use now. So our work basically is around assessments that were done previously, and we were trying to address some of those challenges that what were identified by those assessments, and mainly around availability of commodity data. So some of the gaps that were identified or challenges, suboptimal reporting of commodity data from facilities, poor quality data that affect decision making, such as forecasting and qualification, poor data visibility at various levels, that is facility, sub-county and county level, and even national level. And of course, the burden of reporting at facility and county level due to workload and tedious reporting. The rationale for this was basically, of course, now the fact that, sorry for that. That data for data availability was normally is normally suboptimal, especially for commodities, and a lot of the time is not very accurate, and therefore cannot be used for good decision making. Therefore, for us we identify this as a gap, and we thought that we could do something about it. And therefore, we decided to digitize the commodity data reporting tool and request reporting tool that is at the facility level, and we increased a Qualiform. So when data is collected at the facility level, it is actually uploaded onto the tool, and it's available for review and validation by the sub-county pharmacist. And then from there, it is automatically uploaded onto DHIS, therefore reducing the workload at that level in terms of reviewing paper-based reports, and of course, therefore reduces the workload at the sub-county level. And therefore, since that this tool has internal validation rules, then we expect that the data that comes thereof is of quality. How does it, what is Qualiform? Qualiform is a mobile-based solution for reporting and validating commodity at all levels. It has inbuilt data quality features. It provides real-time commodity data visibility, easy to use at facility level, facility, sub-county, and county level, and therefore, of course, making reducing workload that is associated with reporting. It is an integrated system, meaning once the data is keyed in and reviewed by the sub-county pharmacist, then it will automatically be uploaded onto KHIS. And it is also has a capacity of integration with the KEMSA LMIS. It has all the FCDR for all the program products from HIV, RH commodities, malaria, and recently the EMMS FCDR. It also have an offline mode that allows for use in areas of poor connectivity, and once they're able to access a good network, then they can always upload their report. And of course, we make sure that the data input in the system is secure. How does it work? As I mentioned, data is input at the facility level and uploaded. An alert is then sent to the sub-county pharmacist to alert them that a facility has reported, and a report is awaiting a review and approval. If, for instance, if the sub-county pharmacist looks at the data and is satisfied with the data, then of course they'll just submit directly to KHIS. If not, they will reject the report, and it will go back to the facility with a report, with a reason why the report has been rejected, and therefore the facility is supposed to redo and actually send the report. This is how it looks like. That's the landing page. You have to log in Once logged in, then this is a facility level activity. So as you can see here, we have the various programs. Again, we have also included the essential medicine list. I think it's only that I wasn't able to get that option. So the facility will choose the program commodity they would want to report on. For instance, family planning, they will click on it and it will give this window here, which will actually show all the products that are kept in that or stocked in that facility. And the product will show the beginning balance from the previous month. Then, of course, it requires that you input received quantities, dispense quantities, losses, positive adjustment and negative adjustment. Then you have to ensure that you capture the days out of stock so that it can also properly capture AMC. Then, of course, you put in the quantity to receive. As you can see from this end, it automatically calculates the months of stock from the beginning balance. And then, of course, it can also capture what has been supplied from KEMSA. And therefore, again, also be able to validate quantities that the facility is holding. Then, of course, it will also identify areas where, or cases where quantity requested is below what is needed. So it has those internal validation rules that actually can actually flag that there's probably an issue with the requested quantities. After the facility has sent, as I mentioned earlier, has uploaded the data, it goes to the county. As you can see, this window shows the sub-county, sorry, and this one is Rulambi sub-county in Kakamega. So again, from the other window number 2, the sub-county will see what facility has reported, and the facility will be marked green, meaning that they have reported and the report is pending approval. All facilities that have not reported will still remain in red. But once this is approved again, it turns blue. And here you can actually be able to see, it shows the reporting rates by program commodities. After that, sorry, then you can actually be able to see how the sub-county pharmacist is able to look at the data that is keyed in. If they are satisfied, then as I mentioned, they will just approve, and this data will automatically be uploaded on KHIS within a very short time, like within minutes. If not, then they reject it, and it goes back to the facility level. They can also be able to view stock levels within their sub-county and drill down to facility level to see where these commodities are. For instance, if a facility has, maybe for instance, 10,000 pieces of an item, and the sub-county pharmacist feels that that's too much, he may drill down to see which facility has all the stock, and that can inform redistribution. Again, remember, as they are reviewing the report, the uploaded report from the facility, they can actually be able to see whether those stocks make sense from the facilities. Next, this one is the county window. Sorry, I'm going ahead of time. This one again is a county window, where the county pharmacists from the comfort of the office, they can actually be able to monitor. Just a minute. Sorry, yeah, I think this is it. They can actually be able to monitor what is happening in their county. For instance, this is Homa Bay County, and the county pharmacists can actually be able to see the reporting is by sub-county and by program area. and actually be able to see whether facilities have reported or not, and if they have, whether the reports have been approved. Then again, they can also be able to view the quantities of products in the various facilities, and be able even to see the quantities by product. And of course, from there, then a discussion can start on whether to redistribute or whether the data is correct, or whatever reason may be of what stock status are showing. Coverage, currently the tool is in use in 20 counties in 830 facilities. 5 counties are fully situated in the use of this tool, and those are Homa Bay, Migori, Kilifi, Marsabit. Those ones, all the facilities, county facilities are using this tool. The rest, we have just deployed it in a few facilities, but we're hoping going forward that they will also be fully saturated. And the support normally comes through UNFPA and World Bank through the MDTF project. What has we seen after use of Qualifarm for a year, and though some facilities started using in October? There's improved consistency in the reporting rates. The average monthly commodity reporting rates for the FP commodity specifically has been 96% between March and 2020 and February of 2020. So most facilities started using the product in February last year, that's 2020. And we have seen increased improvement in terms of reporting rates and in terms of consistency in reporting rates. The highest reporting rate improvement was in Tana River County from 43% in March. I think there's a typo there. In March 2020 to 87% by February 2021. Even though the reporting rates has been affected by the recent industrial strike by healthcare workers. West Pokot and Samburu, the improvement was 24% and 15% respectively by January 2021. This is just a graph showing you how the reporting rates improve in Tana River from 43% to 87%. We are also able to get a report from the tools, from the dashboards. We can actually be able to get the stock out rates and what facilities are reporting. This is just a sample of the data that we get from the report, the stock out rates in the counties. We decided to look at the facility level and the time in terms and how they report stockouts. And as you can see, surprisingly, the health centers do have report more stockouts than even the dispensary, and it is least at county referral hospitals. Again, this is just to show how the reporting rates have been improving. This is to show how consistency, how the tool again has improved in terms of consistency in reporting. If you look at before the use of the tool, there was inconsistent reporting, but immediately we deployed the tool, you can see there's at least some kind of consistency in reporting until November 2020. And I think the data that we'll be also looking at up to 2021, that is February, would still show the same. What are some of the benefits? For us, we are looking at improved data quality for decision making. If data is accurate, the decision made thereof, of course, will be more accurate, and therefore will improve on the systems that are already in place. And of course, access of services. Then of course, data visibility and the last mile assurance that the data coming from that last mile end of things is of quality and it can be used to make decisions, especially for forecasting and quantification. Then, as I mentioned, it reduces the burden of reporting and eliminates physical delivery of reports, of course, removing the associated cost. And for us, we saw it work very well with the COVID pandemic last year, from last year March, because as you remember, movement was restricted, and therefore physical delivery was not possible. It worked very well for many countries that were already using it. And then, of course, increasing the efficiency in the reporting processes. As you can see, Migori has done extremely well, and they have maintained that even though there was the industrial strike by healthcare workers, it only went down in January, and again, it picked up back to almost 100%. In conclusion, we feel that adoption and use of technology within the context of the county health supply chain system strengthening can lead to improved commodity data reporting, enhanced commodity data visibility, and improved data quality. And then, therefore, it is critical to invest in technology as part of overall efforts to improve the availability and quantity of commodity data. This is just to show that we have the blessings of the Division for Health Products and Technologies. We were given the go-ahead to use the tool because we were, according to the discussion we had, we were addressing exactly what they were looking forward for, and especially for commodities like the essential medicines that normally have issues with the availability of data. We wish to acknowledge the support of the Division for Health Products and Technologies, the Division for Reproductive Health and Maternal Health, county governments, UNFPA, who have supported in deployment of the tool, MDTF project through World Bank. They have also supported deployment of the tool. Ugavi, through discussions in terms of supply chain, the audits from the counties, and mentorship that goes to the counties. And thank you. Back to you, Dr.